I love that photo. Yeah. Thank you very much. Right, let's move on from that quickly. Right, I'm Bill Newman. Lovely to see you. Thanks for coming out today. So some of you will be aware that today, 28th of February, is International Rare Diseases Day. And people in genetics like myself for a long time were sort of seen, I think, a little bit as a Cinderella specialty, something that was only done in very specialist centres. We spent our time in labs trying to think about genetic mechanisms and why genes were changed. And I think it's there's been a complete transformation over the last 15 years for people realising how relevant genetics is to so many different aspects of healthcare, be it from the individuals and families affected by the sort of 8,000 rare inherited conditions, which we've seen amazing transformation in our understanding of those over the last decade, to also understanding about how genetics is important in lots of more common conditions. So, the transformation we've seen in cancer care with patients who have particular genetic changes, which you can now target with particular types of treatment. We see that in bowel cancer, we see that in types of skin cancer, lung cancer, and the outlook for those individuals completely changed. And an area that Jess will talk about a little bit later, I've got an interest in, is how we respond to our medicine. And we know that sometimes we carry changes in our genes that affects, if we have a good response or if we had side effects from our medicine. And so all this activity, all this is happening. And we've seen that the NHS has focused in more on thinking about what we should be doing and how we should be using this information. And some of that was driven by David Cameron's personal experience and by Gordon Brown's personal experience. So Gordon Brown's son, as you may be aware, has got cystic fibrosis. And David Cameron's son had a very rare inherited genetic condition that caused severe learning disability and epilepsy. And he was one of the first people in the country to undergo a new type of genetic testing called whole genome sequencing. And that found the diagnosis for their son Ivan as to why he was affected in this way. And that gave David and Samantha Cameron some understanding of why this had happened. If you have a child with severe health problems, as a couple, you spend a lot of time thinking, well, how can this have happened? What have we done? What has caused this? And just that simple diagnosis, that information can be completely transformative. And it's the first step into understanding what the treatments can be and what you can do. So that understanding in those families led to the 100,000 Genomes Project, where whole genome sequencing was offered to lots of families with individuals with rare conditions, but also with patients, individuals with cancer, to look at their tumour. So that happened between 2015 through to 2019. And around that time, people started saying, well, we should do some more about genetics and think about how we take this technology and roll it out. And so there was a review of all genetic services. So the three components are the clinical genetics services. So there's one in Manchester, there's one in Liverpool for the Northwest, and we do peripheral clinics. So we come to Lancaster, we come to Blackpool, we go to Blackburn on a sort of monthly basis, and we see patients with a family history of cancer, with family with children with learning disabilities. I tend to see people who have inherited heart conditions, so cardiomyopathy, or where there's been a sudden death in a young individual in a family. And then there was the focus on the laboratories. So the major laboratories for delivering genetic tests are in Liverpool and in Manchester, but we have links to the pathology services around the region, particularly in Blackpool, but in Preston and other centres. And they are delivering thousands and thousands of tests. It's not research. These are tests that go into patients' notes that determine what their treatment should be or what the risks are to other family members. And the third element is what we're sort of focused on a little bit more today is the Genomic Medicine Service Alliance. So these were set up in envisaged in 2018. They started just 2 years ago. So in April, we'll be 2 years old. And the first year we sort of spent just trying to build up the team and to work out what we needed to do. And so now we're really going around the region, talking to people and trying to give people a sense of what it is we're hoping to do. So some of the jobs that we've got and been tasked with are to complete some of the work from the 100,000 Genomes Project. The 100,000 Genomes Project was an amazing initiative, but we only found the diagnosis in about 25% of individuals. So there's still an enormous amount of work to do. You know, that when you read the stories in the newspapers, the vignettes, and how this new diagnosis has transformed this family's life, it's led to a new treatment for a child or new understanding so the couple can make decisions. That's great. It's really fantastic. But it must feel really tough if you're one of the 75% that hasn't got that answer while you're trying to understand what we can do. So we need to work better to try to use the information to find the diagnoses in those people who have participated in that study. We've got a big program of work. If genomics is going to really deliver what it needs to do, it can't be left to clinical geneticists or genetic counsellors. There are only a tiny number of us, and we've got specialist knowledge and we can be supportive, but we can't get out to all the places. We can't get into primary care. We can't get into rheumatology, diabetes clinics. And so we need to make use of the workforce who are in those clinics, who are in those places. So the thousands of nurses, midwives, pharmacists, GPs, other doctors that are delivering services, making sure that they've got the knowledge that they need. We've got a number of transformation projects. I'll just touch on those in a minute. And one of the things that it was quite clear before an update to the laboratory services came, commissioning for genetics was all very patchy. And so it was this postcode lottery. It depended where you lived in the country, whether you got access to a genetic test. And we know that that's not acceptable. Within the NHS, we've always bought into this concept that healthcare is free at the point of delivery. But, you know, that needs to be equitable, irrespective of where you are and who you are, irrespective of socioeconomic status, of where you live, of your ethnicity, of your gender. And so one part of our program is to raise some of the awareness about genetics, say a little bit about what we're doing, but also to hear and listen to find out what it is that people want from genetics. So we're linked in with lots of groups around the region. Michael Gregory, the Northwest Medical Director, chairs our partnership board. We're linked into the Cancer Alliances, the Academic Health Science Networks in Liverpool and Manchester across the region, working closely with public health to understand what are the big health issues. So when we speak to them, they say, well, cancer, mental health, diabetes, cardiovascular disease. What we need to do is think, well, how relevant is genetics to those things? How can we link in with those things? But as I said, rare conditions might individually be rare, but across the whole country affect 3.5 million people. They're the fifth biggest cause of ill health in the country, and a lot of those conditions are chronic. And if you went to the Royal Manchester Children's Hospital today, a quarter of the children in the beds at any one time have got a rare inherited condition. So they have a huge impact. And because they're inherited, sometimes they can affect multiple people within that family. And so they have lots of different impacts. And so we've got a very great patient representative group chaired by Dave McCormack, who's a gentleman with visual impairment, who's pulled together a team working with Barbara to advise us and to give us a steer on the things that they feel are most important for us to do. So that's just to tell you that we've made a bit of progress, that we've got a team of different people. So we've got leads in nursing, midwifery, pharmacy. We've got a team that supports and makes sure that we get all our projects delivered on time. You've got lots of information on our website. We're going around doing a number of engagement events, and we've been taking leadership on certain areas, so particularly around pharmacogenetics. And one of the things that we've been really keen to do is to acknowledge the different communities across our region. So particularly, we've started our work focusing on the British, Pakistani and Bangladeshi communities. So in Manchester, across into North Manchester, Oldham, Rochdale, Blackburn, and then up into Burnley also. I'm doing a number of community events, so going to markets, going to the cricket, going to mosques and working with the British Muslim Heritage Centre. And one of the things that we know is that when we do genetic tests in families from different ethnic backgrounds, we would offer the genetic test just as we would to anybody. There is no barrier to that. The problem arises when we come to interpret the genetic results, because we need to be able to compare to a database of information of healthy controls, so that we can say this variant that we found, we never see that in that population, so therefore we think it's important. But you may have heard of a big study called the UK Biobank study. That recruited 500,000 people across the UK. It's an incredible resource of genetic information, of clinical information. Of those 500,000 people, only 2,000 were of Pakistani origin and only 600 were of Bangladeshi ethnicity. And so when I look at a genetic result, often I'm in that situation saying, we found something, but I'm not sure if this really is the cause. And that has lots of knock-on effects. It means that we can't necessarily start some treatments. It means we can't give advice about reproductive decision-making for those couples. So the more we engage with that community, the more we're able to get samples and information, the more that I won't be, and my colleagues won't be in that position, giving people information that doesn't really help them to move on. So a number of the projects, just to touch on, we'll hear about familial hypercholesterolemia from Gavin, who's been working on that. Jim here in the front row has been working with a number of colleagues here on the Lynch syndrome project with Marie and others, trying to make sure that these are people with bowel cancer or endometrial cancer, might come on at an early stage. There may be a family history. We sort of know what to do, but it's not quite happening. So why aren't the tests happening? Why aren't the people getting the screening? So it's putting knowledge into real delivery and into the pathways. And that's what the transformation's about. Some of it can be about new discoveries, but some of it's about taking the knowledge we have and making sure that we use it properly and effectively. We've been working with a number of the pathologists around the region to make sure that particularly the cancer samples that we need to do testing on get to the laboratory in the right way, and the results go back to the oncologist so they can really make a difference. You'll hear from Deb's about that. And I've been working with colleagues, so Kim Clark, who's a genetic counsellor in Liverpool, looking at the pathway just funded by the British Heart Foundation for when there's a sudden cardiac death or a sudden unexplained death in a young person, usually under the age of 40. We take that, working with the coroners, through a particular pathway. So we make sure the right samples get tested. We make sure the families get the right follow-up, so they have the heart scans, the heart tracings, and those families don't fall through the cracks, because that's a very vulnerable time for these families. Often they don't want to talk about their own health because they're grieving for the young person they've lost in the family. So it's about making sure that those pathways work properly. I won't touch on DPYD because that's a pharmacogenetic test, and we can talk a little bit about that a little bit later. But maturity onset diabetes in the young is a very, very rare form of diabetes. It only affects about 1% of all people with diabetes. But we reckon that's probably about 700 people in the Northwest with that condition. And it makes a huge difference because you don't need insulin. You need tablets, or you need other types of intervention. And that can be completely transformative, not only for the individual, but also understanding that other people in their family are at risk and need follow-up. So I think that's me. The last thing I would just mention as we're talking, as I mentioned my interest in pharmacogenetics, you'll see, I think on one of the, I think it's on the little thing next door, the Halo study, which is something that was on the news on the BBC a couple of weeks ago, just because it got NICE approval. And it's just because it's something close to my heart, I'll just mention for a couple of minutes. So we know that babies, newborn babies, if they go onto the NICU, which about 10% of all babies do, they will be prescribed gentamicin to prevent sepsis or to treat sepsis. And gentamicin is an incredibly effective drug, but 1 in 500 of those babies will go deaf because they carry a genetic change that predisposes them to deafness. Now, we've known about that for 30 years, but the genetic testing that we can do in a laboratory takes 3 or 4 days. And so that's hopeless because you need to give the antibiotic within an hour. And so working with a little company in Manchester, we've created a cheek swab that you can put into a machine. The neonatal nurse can press button. 25 minutes later, they know yes or no, does the baby carry that variant? And then you can give them the right antibiotic. So we ran that in Liverpool and Manchester over about a year. We identified 3 babies that carried the variant, so they got a different antibiotic. And you could say, well, why don't you just give everyone a different antibiotic? Well, the problem is that then you're worried about antibiotic resistance. And so if you only give that other antibiotic just to a small number, that's not a problem. And gentamycin's a great drug. So you think, oh, well, that's good. They've made a new test. I'm sure it's pretty expensive, and it's just adding more cost to the NHS. Well, it is. There is an expense to it. You have to have a machine in each neonatal unit. You have to buy the assays. But if you look at how much it costs to treat a baby with bilateral cochlear implants and all the effects of having hearing impairment, the savings to the NHS are probably somewhere about £5 to £7 million every year. And so that's why NICE just assessed that, and they've given a provisional approval for that test to go and be implemented in every neonatal unit around the country. And what we're looking at now, we're trying to use that technology for other places where using rapid genetic information might be really useful. So particularly if a patient comes into A&E and they've got really severe pain, you might think, oh, I'll give them codeine. Well, actually 10% of people have a genetic change that codeine doesn't work in them. And so if you could just do a cheek swab and get that result, you could then get them onto a different medicine rather than getting them onto codeine. So it's trying to think about other applications for that. So I'm happy to take any questions. It was just a little bit of a whistle-stop tour. There's lots of other stuff going on in genetics, but as is my wont, I just talk about my stuff. Yes, please.
And the information for data. Is this something that can be used in the prophylactic setting? Say when you see a GP, they could screen the food and say, well, you shouldn't ever be given codeine because you're
Yeah. So yeah. So Jess is going to talk about that a little bit later. So that's something that we've just set up. I think one of the things that we want to do is that we've always been quite reactive in genetics. We've always sort of waited for someone to present with a problem, and then we do some tests, and then we try and do something about it, but actually trying to get that information beforehand. So I won't steal Jess's thunder, but it sort of links in a little bit to some of the thinking going on about the revitalizing or changing the newborn screening program. So newborn screening program is a remarkable thing, for PKU and hypothyroidism. It's quite conservative in the UK, a relatively small number of conditions, just 9 that we test for. There almost certainly is compelling evidence to expand that. And there's this big discussion going on, there's big funding to look at, should we do genomic testing in all newborn babies, or should we just expand the type of testing that's already there? And I think it's quite controversial. There's lots of challenges, but that's the direction we're going, trying to be sensible about how we use that information. A lot of genetic information we think is very deterministic. If you've got the variant, that's going to happen. It's not right. There's all shades of grey in amongst that, and so we've just to be a little bit more, I suppose, thoughtful, because the part of the problem is it's not been such a thing in the Northwest, but I know colleagues in other parts of the country, they are inundated with patients coming into clinics, especially GPs, who have gone off and done direct-to-consumer testing. They've got 23andMe tests, they've gone all this sort of stuff. They've found out all sorts of information about themselves, about other family members. Most of it is just wrong and not helpful, but they come in and they're worried, understandably, but it's creating quite a challenge. So we need to use that predictive information in a very thoughtful and tailored way. Oh yes, sir.
Here's two questions. You mentioned postcode lottery. Is that still a thing?
No, which is great. That's one of the really, really big pluses, I think, of the introduction of the genomic medicine service. So all genetic testing is nationally commissioned. So as long as the patient meets the criteria for the test and the test is on the directory, then it's accessible. So a cardiologist can order a test if they've got a patient with hypertrophic cardiomyopathy. But if they've got a patient with they sort of have a patient with a severe ataxia, the cardiologist should really be asking their neurology colleague to order that test rather than them being able to do it. And likewise with cancer tests, all of those are nationally commissioned as well now. So we shouldn't have that. We are going back and looking at testing that. And one of the things that one of our team, so Stuart, who's not here today, is leading a program of work looking at where are our patients who are coming into genetics being seen, where are the tests happening. So if we see a particular region across the Northwest and it's like, well, no one's having any tests from that region, it could be because there's no one affected, but it's more likely that they're just not being referred in or the pathways aren't right there, and we need to look at that in a bit more detail.
The other thing was just, you mentioned, I think the example of gentamicin is really good, but what's going on in the background to kind of assess economically how the provision of services and cost benefit?
Yeah, so we work very closely on most of our projects with health economists. So Catherine Payne is a professor of health economics in Manchester, and she's very well versed in looking at different health economic models for how you disrupt things, how you bring in new technologies, how you look at the impact of these incredibly expensive treatments, but also something called constraint analysis, which is basically looking at none of these things happen in isolation. They all happen in the context of we're already delivering stuff. And you could have a brilliant new treatment, but if you don't have a nurse available, if you don't have a bed available for that patient, it doesn't work. And so it's thinking about not just the cost price of that individual intervention, it's the whole package. And then what are the longer term benefits for society and for that individual? Thank you. Marie.
Bill, just go back to the, I was struck by the numbers that you described in the UK Biobank. Do we know the reasons why the certain groups were underrepresented within there?
To some degree. So when we've been going out doing this Genes and Health project within the Pakistani and Bangladeshi community, I think there are a number of reasons. I think it's quite complex. But first of all, I think that we know for most large scale studies, even this new project called Our Future Health, which has just sort of landed, there's been some sort of stuff in the newspapers about that. We know that the vast majority of people who participate in those sorts of studies are highly educated white people. And there isn't enough effort made to try and get the breadth of recruitment into other areas. And some of that is because the effort isn't made by going and talking to people. Just if you get a leaflet through your door, a lot of people are just going to think, really? There's concerns about how that data is going to be used, the safety of it, the security of it. Will it be used against me? There are lots of examples over history of genetic data. We've seen this in the US with Black individuals who carried a variant for a condition called sickle cell disease, being excluded from jobs, having all sorts of sanctions against them, which is completely inappropriate. And so there's a long-standing history of us not using the information the way that it should have been used. I think really making people understand that the information will be used for their benefit, not for commercial gain, not just because I've got a research project that I'm interested in, and making people feel that they're part of it, so that they're able to ask questions. So when I go and speak in mosques or in community centres, a lot of people, they talk about their experiences and they say, I'm just told we've got these problems in our family because I married my cousin. And so they feel that they're to blame. And so you're not going to engage if all your interaction with the health service has been you feeling on the back foot or feeling a bit negative about how people respond to you. So it's breaking down some of those barriers and trying to make people feel that what we're doing is useful, but actually very much a partnership rather than us going in and trying to do some type of missionary work. Jim.
Lectures, he asked the students, put their hand up if they know their star sign. So all the students put that, and he says, I'll put your hand up if you know your HLA status.
Right.
None of the students put that. So extending from particular groups of society, do you think there's a general anxiety or reluctance to know some of this information about yourself? And do you think that we will be able to change that? How do you think that's going to develop over the next decade or so, would you guess?
Yeah, so that's a really interesting question. So I haven't undertaken any of my own genome sequencing. I could have. I know lots of geneticists that have, and you look at geneticists and we're, I suppose you say that about all professions, and you look at your own, you think, oh, we're a bit of an odd lot. And there are some geneticists and they really want to know. They think it's really important to have their own genetic code so they can make some decisions. I've got no interest in knowing because the more I know, the more I realize the less I know. And also, I would not dream of undertaking a genetic test without chatting to my wife, chatting to my kids, chatting to my sisters, because anything that happens to me is their knowledge as well. And so you've got to think about in the context of a family, which is often quite different from other things that you do in your life. And so I think, there's no doubt there's been a huge success in 23andMe at a commercial level. People do it. People like it. People give it for Christmas presents. There are lots of stories about, people finding out stuff they didn't want to know, that this isn't their father, that isn't where they thought they came from, this sort of stuff, which can, be really challenging and upsetting. Sometimes there's health information. But even looking at COVID, people know what a PCR is now. People didn't know what PCR was. The language is changing. If you look at Fergal Walsh, he's every other night he's talking about something genetic. He virtually lives in a genetics department. He's either at the Sanger Centre or he was in our department a couple of weeks ago talking about this new gene therapy. He was talking about the hearing loss thing. So genetics is becoming much more part of our vernacular. And I think that we are changing slowly but surely the thinking about it as something that's useful rather than something that, it's got a very troubled history, and the history around eugenics, which is very unhelpfully just placed as something that the Nazis did in the Second World War. Absolutely, it wasn't. Eugenics was a completely mainstream way of thinking in England, in America, in Sweden, across the whole of Europe. People at the highest levels of society thought that if you had some disability, or if you had some strange behavior, or if you were put in prison for something, you should not reproduce. That was what people thought. And, we need to make sure that actually we are far more inclusive and we're using genetic information in a way that sort of works for all of our society rather than excludes people. I'm on my hobby horse. Right. Thank you. Look, I'm going to let Gavin talk because I've probably gone on too long. I am really sorry that I will have to scoot off because I'm hosting a meeting in Manchester at lunchtime, but I'm going to stay for Gavin's talk.
Thanks, Greg. Okay, we'll hand over to Gavin.
That's time.
Fine.
While it's waiting to load, I was going to ask a question about the BHF coroner's study. Is that taking samples from the person who's passed away and then screening for genetic abnormalities?
Yes, so it's a project that was based in 7 centres around the country, and the 7 centres were chosen because the coroners came forward because they are the key individuals that sort of, you know, control the process right at the start, working with the pathologists. And so we've been doing that in North Manchester. We're going to start in Liverpool in the next few weeks, and we're hoping to start in Blackpool.
No, very interesting, because we do have sudden death, and then the family are real family issues. So that's very interesting. Thank you very much for inviting me today. So I'm Gavin Glasgow. I'm a cardiologist. I'm not a geneticist. I'll do my best. So I treat heart disease, but one of the conditions that was quite clear that really wasn't being detected or treated is familial hypercholesterolemia, genetic high cholesterol, high lipid levels. And there's certain therapies that can only be prescribed from secondary care, and there was no secondary care clinic in Blackpool. So I set up that clinic a few years ago, and we've had some interactions with Northwest Genomics, and we're going to present some of the work we've done on familial hypercholesterolemia. But I thought I'd give you some background, give you a clinical talk as well as a genetic talk. So what is FH? I'll call it FH. So it's an autosomal dominant condition, and as mentioned, it's to do with lipid metabolism, and you get very high LDL cholesterol, which is what we hear is bad cholesterol, and very high total cholesterol, and patients get heart disease, coronary heart disease, furring up of the arteries at very young ages. So it's a nasty condition, undiagnosed. We now know the genetics of it, and it usually results from mutations in the LDL receptor, the receptor on liver cells that grabs LDL and removes that type of cholesterol, bad cholesterol, from the bloodstream. Because it's not working properly, it doesn't remove the cholesterol, and you have very high cholesterol levels. There are other parts of that pathway to do with LDL, apolipoprotein B, PCSK9, the adaptive protein gene, and there are mutations seen in all of those proteins as well. And similarly, you get less LDL cleared by the liver, and you get high cholesterol levels. Outcome is very much related to how high your lipids are and for how many years. So it's a bit like smoking pack years. How high times time, that gives you a lifetime exposure to high cholesterol, if you like. And so early treatment and testing of relatives at a young age is very important to improve outcome. It's actually a very common condition. If you Google commonest inherited condition, it doesn't come up. It's not thought of as a genetic condition, which is astounding, actually, but it's more common. It doesn't add up to 3.5 million because it's one of the 8,000 congenital conditions, but it's the most frequent, and this is probably an underestimate. It's probably nearer 3 or 4 per 1,000 births, so it's many times more than some of the other conditions, but it's not really discussed or thought about, which is a surprise. It's undiagnosed, so this is slightly old data on the left, but in 2008 there were only less than 20,000 people known to have it. In the country, there's probably 250,000 people. So somewhere between 7 and 15% of people with it are diagnosed. Where are the missing 85% of people? And it's a horrible condition on the right. This is old data before we had treatments for high cholesterol. But if you had high cholesterol and you're a man, by 50, half of the time you'd have had a heart attack. And by 70, everyone would have had some heart condition or other. So it's a nasty condition untreated, and for women as well, it's a nasty condition. So this has now been understood, and genetics has now been understood a bit better. And as Bill said, there are some drivers now to pursue and to look for FH and other congenital conditions or inherited conditions. And the NHS long-term plan, which is 4 years old now, recognised that there should be benefit from genetic testing for FH. We should be diagnosing it. We should be treating it. It noted, using the data I've quoted, that perhaps only 7% of people with it are diagnosed with it. And the aim by next year is that 25% of people with it will be diagnosed through the genomics programme. Are we anywhere near that? Probably not, but there is a target for next year. Because of that, there's now funding for GPs. So there's a real driver. So this is the Investment Impact Fund, and it basically pays GP bonuses, the percentages of patients who have the following, and there's a whole list of conditions. If 50% have this, you get this much. If 30%, you get this much. And FH is one of the cardiovascular, so CVD4, and it will pay GPs if they have screened for, assessed patients for, referred patients for, and had patients diagnosed with FH. So there's going to be a lot of referrals, and so we've got to be ready and prepared for that. And I think we partly are in Blackpool, and hopefully a bit in Lancashire and Manchester as well. So this is kind of the pack year history that I was talking about. So in blue, we've got non-FH. In red, we've got FH. And at a young age, you have much higher cholesterol than the normal population, and it stays higher and higher and higher. So your lifetime exposure, your total cholesterol times time goes up. So at the age of 40, someone with FH really has the exposure to cholesterol of someone at the age of 70 normally. And by the time you're 50, it's off the screen, it's 85. So this is the point that by 50, by 60, by 70, undiagnosed, untreated, you're in trouble. But really, differences start at a young age, and the earlier we detect it, the better we can do. And this is shown here. This is in black and white. I'm sorry about that. But for non-FH people here, FH, you do nothing, their cumulative LDL goes up. If you detect it at age of 10 and start statins, by the time they're 50, they'll have had the same exposure, and you can have normal life expectancy, normal outcomes if you find this condition at a young enough age. Even at 18, by the time they're 50, they're not that different from the general population. So it's an important condition to find at any age. It doesn't matter. But with cascade testing that we'll talk about, you can find it at a young age, and you can really make a very strong difference. So there have to be treatments. There's no point detecting things if you can't treat it. But you certainly can treat FH. It's all about lowering the LDL cholesterol, and there are a number of clear-cut evident treatments that work very well. Obviously, you do offer diet and health advice. That's not going to be the mainstay, but it's important. You can do a lot for your cholesterol and your health with good diet, with good healthy lifestyle. Statins, which are dirt cheap now, are the mainstay of treatment. We're talking about cost effectiveness, was one of the questions before. And there's data, the first trials in FH reduced heart attacks by 76% over 12 years. So a massive difference by lowering cholesterol. They don't always get your cholesterol low enough. They're strong, they might lower it by 30 to 50%, but when your cholesterol's up here, that's not enough. And we now have injectable agents. And that's actually why I set up the lipid clinic, because you can only prescribe those in secondary care. These are injectable agents every 2 weeks that can lower your cholesterol by another 50% on top of statins. They're very, very effective. They're NICE approved if your lipids remain high. If your LDL cholesterol remains high, despite statins, we can prescribe these in subcutaneous injectable therapies, PCSK9 inhibitors. There are second-line treatments as well, if they're not responding to statins or injectables, but really those are second line. We should be trying statins first line. You'll have heard of ezetimibe. Bempedoic acids are kind of substitute for statins. Again, at the moment, we can only prescribe those in secondary care, and fibrates are slightly old-fashioned, but there's still a role. There are specialist therapies for FH, and really the big centre for this would be in Manchester, and you can do plasmapheresis or apheresis, where you like dialyse the cholesterol out of the bloodstream. The liver transplant will deal with the problem of the genetic problem in the liver, and there are some very expensive drugs if your cholesterol is through the roof. So if you've got both genes, if you're homozygous, you get very, very high cholesterol levels, and then there are some cost-effective, expensive treatments that we can offer as well. So how do you diagnose it? Well, as well as a genetic diagnosis, we start with the clinical diagnosis, and this is a condition that does have some clinical diagnostic criteria, and the NICE guidelines describe this very clearly. So NICE is excellent. If you've looked at their guidelines, they look at lots of conditions. They give best advice, best practice, best diagnostic criteria, best therapy, and then they say what is cost effective, what does the NHS support giving, and they give very good advice. So what they do say is think about it, and that's, I think, the one message for GPs. Think about it. Could it be FH? What was their cholesterol? And anyone with a cholesterol above 7.5, maybe we've got to start thinking about it. Maybe they need treatment. Doesn't mean they've got FH, but we should start thinking about it. If there's a family history of heart attacks at a young age, under the age of 60, again, we should be thinking about it. Because we're looking for it, they say that GPs should systematically search for patients who might have it. And so there's a lot of screening and automatic on GP databases to look for people who've got high cholesterol. And the cutoff suggested are if it's less than 7.5 under the age of 30, if it's, greater than 7.5 under the age of 30, and if it's greater than 9 over the age of 30, we might be dealing with FH. It's important, as mentioned, there are things that can cause high cholesterol that are not genetic. So terrible diets, we've got people on terrible diets actually in Blackpool, certainly. Uncontrolled diabetes, uncontrolled thyroid problems, heavy alcohol. There are other things and lifestyle things that need to be looked at first, and it's important to manage those. There are a couple of criteria or scoring systems that we can use and that are recommended to use. And NICE recommends the Simon Broom criteria, which I will mention, and the Dutch Lipid Clinic score for a clinical diagnosis. And then when you've done that clinical diagnosis and you think that it's possible or probable or definite that you've got FH, and there's some benefit from genetic testing, there's not always benefit from genetic testing, then it does recommend that. And we are now able to do tests for FH. And then if we pick it up, we can then screen first degree, second degree, and even where possible, third degree relatives for this gene defect as well. So these are the criteria, they're very straightforward, really. They've got cutoff. So if you've got a cholesterol above 7.5 or LDL above 4.9 in an adult, and you've got xanthomas, which is cholesterol deposits in the skin, in the tendons, and I'll show you some pictures, or you've got a clear gene abnormality, then this is definitely FH. Possible is those cutoffs plus this family history. So either a family history of a heart attack under the age of 60 for first degree relatives, under the age of 50 for secondary relatives, or a family history of high cholesterol levels. That will score you as possible, and we are commissioned to do genetic testing. I haven't gone through the whole Dutch lipid score. It's complex on the slide, but you again assess the history, the family history, the examination for lipid deposits, and the LDL cholesterol cutoffs actually give you different points. So above 6.5, you'll score 5 points, and it's very likely you'll start to consider genetic testing. And the cutoffs there are 6 or above, so probable FH or above. So these are just some pictures of xanthomas and xanthelasma. This is the fat deposits under the eyelids. You may have seen that. These are much rarer, actually, deposits in the tendons, deposits on the hands and the skin, and that makes it much more likely. They've had high fats for a long time. So I wanted to just mention what we do in the clinic. So as a clinician, and we get referrals. So we set this up, as I said, in the end of 2018, predominantly because of therapies that couldn't be given in primary care. We've grown over the last 5 years. We have an advanced practitioner, we've got 2 cardiologists, a pharmacist, and I'm hoping that we'll have a clinical biochemist soon, which will be very exciting. We started as a monthly clinic, and now we're actually seeing patients five days a week, and we've got a weekly MDT, so it's a busy clinic now. We see 3 real sort of sub-classifications, if you like. Certainly possible familial hypercholesterolemia, that's very important. unexplained high lipids, which might be cholesterol, it might be triglycerides, and whether they've got a family history or not, if they're very, very high, something's going on. It could still be FH. We've got to have a think about it. And then there's patients who've had events, have had heart attacks, and their lipids are not controlled. They're not coping with statins or whatever. And we need to offer some support there as well. So it's all aspects of lipids, but FH is a part of it. Just to show that it is out there, I don't know if people know normal ranges, but most cholesterol is around 5 or 6 or lower, hopefully. We are seeing people with high cholesterol. So the average cholesterol has been 9, and their numbers have been up to 20. I mean, they've been through the roof. So I wasn't quite expecting all of that. And almost all of them, 90%, are above 7.5. So the referral criteria is working very well. GPs are very good. Colleagues are very good. We're seeing the right people. So just finally, we're here to talk about genetics. So we do genetics for FH. As Bill said, it was commissioned in April of 2021. So before that, we weren't able to do any of the tests. We did have a list of people we wanted to test, and we were in communication probably for a year or two saying, when will it happen? When will it happen? When will it happen? And then boom, we set people out. And although I'm not going to show it, I thought it was very interesting. Our first 40 patients had a very high pickup rate. So we had kept the high risk people. I think you'll see our pickup rate in a second, but we doubled that for the first 40 because we went for the people we kept. We want to do the test. So you can kind of prejudge it, and we did, and it worked. But thankfully, and I'm really grateful for Northwest Genomic Medicine Service Alliance that last year they gave us some funding to expand. So I've mentioned Marie and 5 clinics a week. So she's full time with us now on a 12-month secondment. We had her funded for half time, and through this society, she's funded full time for a year. I don't know if that can carry on, Bill, but runs out in June. We'll talk. But I'll show you what we've done. She's done a really good job. So she's first of all been trained, and there's a course you can go to. There's a lot of counselling. There's a lot of family. It's very important at all ages as well. So she's gone on a course at Northumbria University. And we test as per the NICE protocol. So we use Simon Brim, we use the Dutch lipid score. We counsel, we consent, we take blood, and we send blood. We've also started to screen family members and do the cascade testing. So I'll show you some of the numbers. Bill won't have seen this, but in the first year, when it was commissioned, in the first 8 months or so, we did 40 tests. The majority, so 90%, were on new patients. Have you got FH? Yes or no? And only very few were on cascade testing. And actually, the pickup rate was very, very high. I think it was 25%. 1 in 4 that we sent was positive. Last year, with the extra support, we've managed to quadruple the numbers. So we screened 160 people last year for FH. And we've done a lot more of the cascade testing. So about a quarter now are family members. And this is our overall pickup rate. So we've picked up 41 cases. So I think it's pretty good going. For people, do you have it? Our pickup rate's about 14%. It's about 10% now, and it was about 25% for that first bunch. It's about 1 in 10 have the genetic abnormality, which I think is par for the course. Cascade testing, you expect 50-50. We're not far off it, and it's about 40%. So I think we've done a very good job. We've picked up 41 people. They are now going to be managed. They can be advised. Their family members can be tested. We're going from strength to strength. I thought there'd be lots of geneticists. I don't understand this, but here you go. As expected, it's the LDL receptor. So the vast majority were variants in the LDL receptors, so 36. But there were a few with this PCSK9 abnormalities, a few with 1 variant or 2 families with apolipoprotein B variant. So it fits with what we expected to find. There's over 1,000 mutations out there. So there's a lot going on, and we've picked up 40 already. No, 20, yeah, 40 or so. So this is really my last slide, just to say what patients get from it, because as well as, we're diagnosing it, but it's a very positive thing, genetic testing. That's okay. And we found that when there's a genetic test that's confirmed, patients, their motivation levels, their compliance levels, their, how involved they are wanting to be okay, to take tablets, to look after themselves, definitely goes up. They're very much engaged. They're very engaged for family testing, cascade testing. They want to know, are their children at risk? and what can we do about that? And we've discussed cost effectiveness already, but statins are dirt cheap, and heart attacks cause a lot of morbidity and mortality. And early testing is a very positive test, and it gives people normal life expectancy. And we've had an 11-year-old, 12-year-old. We're starting to find children with this condition, so I think we're doing a good job. So that's me. Any questions?
Very interested that we have a lot of people in your clinic look as though they've got this condition, but there's over 80% haven't.
Yeah.
The question is, how many genetic causes do you not know about, and what do you do with that group? Do you, you discharge them and say, sorry, you haven't got the genetic?
It's a really good question, and we're struggling with it a little bit, but it's more complex than this. So these are the people with a single gene defect that says this one single gene causes this massive jump because there's a massive change in that LDL receptor behavior, the LDL behavior. But how many genes do we have? A lot. How do they interact? In a lot of ways. And how many people have polygenetic abnormalities that run in families? So a lot of the work on FH, above and beyond the single gene defect work, is polygenetics and multiple small changes in your genes. You might have 1,000 small changes in 1,000 genes that puts you up here. And you can do some polygenetic testing as well. So that's not commissioned where we are. There are some lipid clinics who are paying for that to be done, and they get a polygenic score to say, actually, it is still genetic, it still is running in your families, but it's not a single gene defect, and that's adding a lot of information. That's not commissioned. I don't know if that would ever become commissioned, but that's another probably at least equal number of people who have a polygenetic, and then we start looking at other factors as well. Does Bill have a comment? I don't know.
Yeah, I can just say about the commissioning. So every year, the genetic test directory is looked at, and so clinicians can write, or patient groups or charities can write a case to say, actually, this should be added. And that is based on the clinical usefulness or utility of that test, how much it will cost, and then what you would do with that information. So the Bristol laboratory, which was sort of leading this alongside Steve Humphrey's lab in London, up until the sort of test directory started, were offering that as a sort of routine test. And I think that if Heart UK and a group of clinicians got together and wrote a case, that would be looked at to see whether generating polygenic risk scores sort of flips over the threshold of, yeah, actually everyone should get this. I don't think that case has been fully met yet, but I know that there's lots of conversation about it.
And there are some lipid clinics who send blood to Bristol. So Bristol they charge, it's not commissioned as such, they have to pay for it, but that is done. So that's one aspect of it. The other aspect, which is important, and I've come to appreciate, is this idea of clinical FH. So we've got definite, if you've got the genetic abnormality, it's definitively, you've got FH, you've got a single gene defect, you have a diagnosis, and all of that comes from that. If you've got a clinical suspicion of possible or probable, once it's probable, then clinically we're happy to treat patients as clinical FH, and that fulfills the criteria. So you don't say, go away, you've still got the high cholesterol, you're still going to have the high cholesterol. We certainly do have people where we think it's lifestyle. We have some horrific lifestyles, and I was surprised how much of a difference it does make to your cholesterol. To your triglycerides, it makes a huge difference. And the other thing actually is that in FH, you normally don't have a raised triglyceride. It's normally purely LDL cholesterol. And so if you're seeing everything is up, then maybe there's something else that's going on. So you're absolutely right. A pickup of 15–14% in people who've got these high values, I actually think it's quite good. Some of them will say it's not FH. We don't actually think you qualify for these advanced treatments. Some of them will say clinically you do, so you can have them. So we're allowed to do that. We're going to learn a lot more over time. There were some other questions, I think. Yes.
What is the high prevalence in certain ethnic groups?
It's a very good question, and from our data, I haven't got enough numbers to tell you the answer to that. I don't know. I mean, it's such a common condition, 1 in 250, but around the world it's different. And so there must be differences, and it must depend on all sorts of questions, but I don't have an answer for that, but I'm sure the answer is it must be. I don't know.
I think the general consensus is that it's fairly even, the prevalence across the world. The big issue that that some communities face, where there's consanguinity, so marriage within families, and 2 individuals are both affected as parents, there's a much higher risk of having this homozygous form with a very, very severe early onset. So those children who need plasmapheresis need to go to a specialist centre. So we are working with colleagues in Blackburn particularly to see, is there a way of identifying parents so that they can then be aware of potential risks to their children, because it's something that you absolutely need to intervene at an earlier stage.
Yeah. So yeah, if there's a chance that both parents have this condition, then it's very, very important to start before the age of 10. So really it's age of 5 we're talking about, or younger. So that's absolutely right. I think there was a question over here.
Just going to say about cascade testing, you mentioned 2nd, 3rd generation. That completely up to the discretion of the patient whether they're contacting again. So to the patient side, in once they receive the result that they didn't want to share out with the rest of the family, that would just
so it's a really good, so definitely yes to that. The patient owns that, and we would not insist on calling other people. Usually we find that they do, but the question is, how do they get screened? Because obviously we're a local service, they might be in Canada. So we do try and see people who live nearby who are able to come or interested in coming. There is choose and book. You can book an appointment at our clinic through the NHS appointment system, and we can have referrals. So we do take, for around Lancashire, but usually we'll say recommend that they see their local GP and get referred to their local lipid service. But it's we would not go behind the back of the patients. No, they normally start talking. Also, you saw in the diagnostic criteria, both of the criteria I mentioned, if the families have very high cholesterol levels, that helps make the diagnosis as well. So they're often going away talking to brothers and sisters and parents and saying, what's your cholesterol? What's your cholesterol? And for the polymorphic, we're not finding a gene defect. We still say, please make sure your children's cholesterols are checked, because we still don't fully understand all of this. And there's certainly clinical FH as well as single gene defect FH. So knowing your family's cholesterol levels is very important in this condition.
Do you mean when you say you've done the cascade screening and paediatrics are picked up, are they then referred into Alder Hey or IMCH?
Yeah, absolutely. So good question. So we kind of refer to Manchester actually. So we've got links with Royal Manchester Children's Hospital, and thank you very much. So we've heard, first of all, we've got our paediatricians in Blackpool. So we're not a paediatric service, so we work with the paediatricians. We can do cheek swabs for children, so that makes a huge difference. And then working with our paediatric team, we refer to Greater Manchester. That's right. Well, the Alder Hey are setting things up, so yeah, watch this space.
Obviously, lots of GPs and their awareness of this condition. Curious to know, the clinics that you've established now, you're seeing patients every day. Are you confident that all the GPs know about this and you're seeing all the patients, or is there still a gap and you need to?
Yeah, so it's a very good question. There is a lot of learning to be done. This has happened all very quickly, and we're trying to do that. So as Bill mentioned, some of the links with the Academic Health Sciences Network, or for Lancashire called the Innovation Agency, we're doing a number of webinars. So I gave the first webinar a few weeks ago, linked Lancashire, South Cumbria, Cheshire and Merseyside. So linked in with the Innovation Agency to talk through the whole of cholesterol management, but there will be a presentation on FH in a couple of months' time. We've got a group from representation from primary care, from the cardiac network, from the lipid clinics around Lancashire to come up with a a briefing paper for the ICB. So the whole way that the health service is now funded and commissioned is you have these integrated care boards, and they have come up, or they're coming up with a cardiovascular prevention policy, and we've got some ideas of how it can be done. A lot of that is education and developing pathways. So there isn't actually a fully formed Pan-Lancashire pathway, and there isn't actually a completely agreed strategy. This is all work that's happening, but it's a very important question because we don't want it to be the case that also, can the lipid clinics cope? The real worry actually that we have, is that we won't cope. If the GPs send everyone with a cholesterol above 9 to the lipid clinic in Lancashire, they'll have a 2-year waiting list to see a patient. So we're trying to work out the best pathway. Should triglyceride levels be important? Does family history matter? Where do we draw the line? So we're working on that at the moment. I think it's important that GPs know about it. We're doing education. One of the things Marie does at the time is funded is go and talk to GPs and primary care education. At the moment, we can cope. We've got this extra nurse for some of the time. Might not have that person in 6 months' time. So it's a very good question. I suspect we are going to struggle unless we get a good pathway and we get funded. Good question.
I'm curious to know as well, because obviously that's got a knock-on effect downstream. So is there enough capacity at the GOH to do that genetic testing as well?
Yeah, so I mean that's a good question. I think what we found is that we did do a little pilot project in Blackpool where we went in and got them to screen their data, see what they had, and then to make sure it wasn't sort of nonsense. Then a consultant actually went in and checked them all and then referred them to us. And what we found, the first 20 patients that came that way, is actually most of them didn't fulfill the criteria for FH testing at all. A lot of the data in GP practice isn't very accurate. So it's going to make life very difficult. But we found that they did have high cholesterol and they did need treatment. So they were right to come to the lipid clinic, but they didn't actually, not that many ended up having genetic testing. So at the moment, I don't know if there's capacity. There seems to be capacity for our 160 tests last year. We're going to have to work together, sort of a Pan-Lancashire approach, pathway, including the genetics labs in this. But if GPs are paid money for doing this, and if the long-term plan says this should be done, we'll have to come up with pathways and we'll have to fund all aspects of those pathways. But I think it's very early days. I mean, as I said, Google most common inherited condition, it doesn't come up. It's not mainstream. It's not thought about as an inherited condition yet, but I hope it will. Any other questions? Thank you very much.
Jessica Key.
Thanks. In case she didn't recognise me, I need some water. We'll try and move on very quickly. Hello. Hi everyone. So I'm Jess, or Jessica Keane, that's my face, here it is as well. And I'm the pharmacy lead at Northwest GMSA, and I'm a pharmacist by background. And today I wanted to talk to everybody about pharmacogenomics, which, as Bill mentioned earlier, is one of the key areas that we're leading on up in the Northwest, and it's the focus of one of our national transformation projects at the GMSA. And the reason I want to talk about that is because we know that there is huge variation in how individuals respond to their medicines. Everybody knows that different people respond differently to the treatments, even though they may be taking the same drug at the same dose. And there are many reasons for that. It might be that they're not taking them properly because they're not sure that they will work. It may be that the dose is not quite right for them. And it may also be because of genetic variation. And all of that amounts to poor medicine's effectiveness and adverse drug reactions, which are a huge problem across the NHS and for individual patients. I always like on this slide to highlight the fact that there are many other reasons why people may not respond to their medicines, and it might be drug-food interactions or drug-drug interactions. It might be their other multiple health conditions that they have, their gender, various other things. When we talk about genetic variation and pharmacogenetics, one of the examples that I'll give here, and there are other types of variants that you can have, is where a drug, A, is metabolized by an enzyme, B, into the active metabolite that actually goes on to have that effect in somebody. If a person has a genetic variation in the gene that codes for enzyme B and they don't have it, they cannot metabolize the drug, and therefore they don't get the active metabolite, and that's why they may not have the effect. So that's the kind of thing that we're talking about when we talk about genetic variation. And why that's important is that when people have a pharmacogenetic variation, they're not necessarily aware of that variant. They're not different. They don't present differently. They're walking around their life. It's only when they have the medicine and they don't respond to it that we can see that they have this variation that makes them different from the next person. And why does that matter? Like I said, medicines are not effective in the vast majority of people. They may work in between 1 and 2/3 of people. In some people, they simply just won't work, and that's it. In others, they may have a serious side effect. And the result of that is around 6 to 7% of all UK hospital admissions are actually related to adverse drug reactions, which is hugely inconvenient for an individual patient at best. And it's also hugely, hugely expensive. So recent work done in Liverpool in last year or the year before estimated that the cost of over £2 billion to NHS. This is huge money, and it's hospitals and hospitals full of patients just because of adverse reactions to their medicines all over the country every day. And there have been large biobank studies that show that actually, depending on the size of the gene panel that you test, pretty much everybody will have at least one change in a gene, in a pharmacogene. So this is not something that is very, very rare. This is the other end of the spectrum to what we've been talking about. Very, very common because they're not conditions. It's just changes in how we handle our medicines. And if you look at that across the NHS, about 1 in 5 of all new prescriptions in primary care actually have an actionable drug gene interaction. So that's a patient who has a genetic change relevant to a medicine that they're taking. So that's completely massive. I think you can all agree. So there's a huge scope for us to improve how we use medicines and optimize them for patients. And recently, the study was published just a couple of weeks ago in the Lancet, but a massive multi-country European study across 7 different countries in Europe. There were testing sites here in the UK as well, again in Liverpool, that showed if you implement a 12-gene pharmacogenetic panel test, so you test all of the patients, that actually with the control arm, they showed that you could reduce the risk of adverse drug reactions in the patients who had the pharmacogenetic panel by 30%. And that is without full uptake of recommendations. So only about 70% of the pharmacogenetic recommendations were then enacted by prescribers. So if you imagine if that was full, potentially we could have reduced the risks even further. But even at that 70% uptake, we've got a 30% risk reduction, which for a single intervention is pretty enormous. I think most people would agree. So that's the PREPARE study if you wanted to read a bit more about it. And so, as I think you were alluding to in your question earlier about preemptive testing, the issue that we have is that current practice a lot of the time is that only when a patient presents are they eligible for testing. We then do the pharmacogenetic test. That may take weeks or even months before we have a result available to inform a prescription. We've got examples where there's point of care testing, like in the PALO study, where we can test the neonates before we give them gentamicin. They present, we do the test, and we get that really rapid turnaround. But if we want to do a panel test preemptively, what that means is that we do a test at a fixed time point before a patient has maybe started on certain medicines. The results are available and they're integrated within their health record. And then those results are available at multiple time points throughout their life. This is genetic information. It's valid for a lifetime. And so if we're going to test for one gene change, why not test for multiple, do a panel, and the results are available and they're always going to be there and they can inform not just one single prescribing episode, but multiple. Prescribing is the single most common intervention in the NHS. It's the second highest cost, I think, after staff. So if we can do a panel test that can inform prescribing at multiple times, there's a huge opportunity here for both patient care and for cost saving, I should say. And so one of the things that we're looking at in Northwest GMSA is delivering this national programme. We've called it the Progress Programme, about implementing pharmacogenetics in the NHS. And we've chosen to do that in primary care for the reasons I said, that that's where the vast majority of prescribing happens. So we've been working quite hard over the last year to validate a pharmacogenetic panel that's going to be used for the trial. That's going to be done in our lab in the Northwest in Manchester. We've then been developing an informatics solution to support pharmacogenetic guided prescribing. So that's to develop a tool that will take the results from the lab and interpret it for the GPs and the pharmacists in primary care to be able to interpret that. And we've done that with co-design workshops with stakeholders, so that we're trying to develop something that is really useful for them and designing it so that we're not telling people this is what you will use, but actually working alongside them to find out what would be useful. And then work package 3 is the clinical trial itself, where we're going to implement that in 4 practices across the Northwest. And I'll talk about that a little bit more. But all of this is being done alongside implementation science evaluations, along with patient engagement and public engagement, and also with the health economist, because we can't just do this and hope that it's cost effective. We need to know that it will be cost effective use of NHS resources. So I'll just briefly talk about the test. What we did, we analysed a number of different assays in the lab. I say we, it wasn't me, it was somebody much cleverer who's a scientist who knows about these things. They used validated samples with and without variance control samples to assess a number of different tests. They looked at the performance metrics, so obviously how sensitive and specific the testing was, but also how much it cost and how rapidly it could be turned around, because in primary care, if we're going to test patients, we can't be waiting 6 weeks before we initiate prescriptions. And we managed to find a final choice, which has been presented to the National Working Group. It's the Agena Veridose core system. And we're also going to be doing digital droplet PCR for copy number variants, which is really important for some of the common pharmacogenes. And our panel tests around 20 different genes, and the turnaround time is 1 day, which is, as you'll agree, if you've heard about genetic testing, significant paradigm shift in terms of the time that it takes. And it's also relatively cheap. We're talking about £20 per patient. So this is not highly expensive, thousands of pounds genome screening. This is targeted panel that costs about £20 each. So that's what we're going to use. Again, this is not nationally commissioned. This is just a test that we're going to be using for our pilot project. I just want to make that clear at this point. And we've designed it in such a way that if the technology changes and new technology becomes available that is more accurate or faster to turn around or more suitable for the systems, that is something that we can change. So we're relatively agnostic on who the provider is. We just need to use what's sensible and available at the time we're in. The next thing that we need to do is make sure that the pharmacogenetic data that we return is available in a clinically relevant format, as well as the time frame. So we've found something that's going to be fast enough, we think, to turn around in primary care, but it needs to be in a way that's relevant and interpretable by the people in primary care. And the reason for that, as Gavin nicely highlighted earlier, is that genetic variation looks a bit like that, which is generally quite unreadable. It shows there's a change from a G to an A at position 636 on the gene. Great. Okay, very good. What does that mean? I don't know what that means. I don't know what to do with that. So that's the genotype. So we need to convert, and pharmacogenetics is reported in a slightly complicated system called the star allele system, which makes a lot of sense if you understand about autosomal codominant inheritance, which again, most people do not need to know about. What that actually means is that our patient who we've want to start clopidogrel in and we've sent for CYP2C19 testing is a PM, poor metabolizer. So that means they're not likely to be able to metabolize clopidogrel. And again, is that useful to me, or what do I really need to know? I need to know what the guidance is around that. So yes, they're a poor metabolizer, but what do? I need to prescribe them an alternative antiplatelet. And that's the level of information that is actually going to be useful in practice. So that's what we'll be doing in Work Package 2, developing this solution that is not just going to give results, but give something meaningful on top of that. And we call it GPAS, Genomic Prescribing Advisory System. And what that will do is it'll ping off to an API. CPIC is the Clinical Pharmacogenetics Implementation Consortium guidance. So it's peer-reviewed international guidance. And you can go and query that guidance and it'll give you the result for that patient, the guidance that's relevant for that patient based on their genotype. And so how it will look in brief is that on the left, you've got the lab at MFT, where the genetic variation, and again, it can be agnostic. So if we change the assay, that won't matter. What's important is that our tool can take the patient's genotype, convert that into a phenotype, and that will be held in a clinical data repository on these open standards, FHIR standards and HL7 messaging that can be used. The GPs are on the right-hand side, and again, it shouldn't matter which system is used, which EHR, so be it System 1 or EMIS. We're also looking at integration in secondary care with EPIC. In phase 1, we don't have this solution yet, so we've got a standalone tool, and what that means is that the GP will have to go and log in to a separate platform called Geno and pull out that patient's result and that guidance from there. But we know that that's very disruptive to a normal clinical workflow. So what we're working on is really for phase 2 that we have a way that we can push this information out from the open standards into their prescribing system, so that at the point you're prescribing in primary care, GP types in a drug and it will ping up what the patient's result is if it's relevant to that prescription. And I'll just show you now a little bit what that looks like. So you would go and log in. This is John's login, not mine. But you log into the standalone platform, you search your patient. This is not a real patient, so don't worry, you're not seeing anything you shouldn't. But it is all connected to the spine, so they'll type in their NHS number. And if the patient's been recruited to the study because they're going to be started on, say, citalopram, for example, that will auto-populate and it will show you what is the guidance. So for this patient, they're a CYP2C19 normal metabolizer, and it's green because the guidance is to just go ahead with the starting dose that you always intended. Okay, so that's roughly what it will look like. In the second phase, they won't have to log into that separate system. So the similar guidance will pop up, but it'll pop up within their own local EHR. So the trial. The timelines on this are roughly appropriate. I think we're now looking at probably more like a May start rather than April. We'll run that for about 6 months in 4 practices just in the Northwest, across Greater Manchester and Liverpool. Not sure there's one in Cheshire anymore, but that's where the practices are. We're going to be recruiting patients in primary care who are going to be started on one of a statin, a PPI, or an antidepressant. And that's because they are drugs that are very commonly used, that have got clear clinical guidance around what to do if you've got genetic changes, and also because they're still not that urgent turnaround. So we think it will take around 7 days to get the sample from the GP to the lab, tested, and the results back again. So it needs to be, in general, medicines that are not required incredibly urgently. But when we do that test, we don't just test one gene. Of course, we test the whole panel. So we have results that are informative for this prescription, but the results can also be held on the patient record to inform future prescribing as well. And this has all been done via research ethics. So that's how the trial itself will work, and the results will be returned to those GPs and pharmacists who can then use it to inform their patients' care. What we're going to be looking at is the process outcomes, and that's a big focus for us now. There's an awful lot of science that's shown that pharmacogenetics works and should work. We've got the PREPARE study that's shown a 30% ADR reduction. What we've not seen is, does this work in normal NHS settings, in our primary care clinics, using our own resources in our labs? So that's what we're looking at. Does the process work? Do the results come back in time? Can the GPs and the pharmacists actually understand the results and use them to inform prescribing? So these are the things that we're going to be looking at in phase 1. And then in phase 2, again, we've got the integration happening within the individual EHRs, but we're also expanding our recruitment geography. So it won't just be practices in the Northwest, we'll be going all across England. Again, we're looking at other EHR providers. So initially, we're looking just at EMIS. That's just because that happens to be the system that's in use that the practices have chosen. So we need to be able to make sure that we don't have results that are only tied to one vendor, because we know there are multiple different EHR vendors across the UK. So we need to be able to interact with all of them, and also in secondary care, because these patients don't just have a GP and stay there, they come to hospital. And so the secondary care clinicians also need to be able to use their results to inform prescribing there. So that is our aim, that hopefully the patients who are recruited will prove that this is a beneficial system that is also feasible, that can be delivered, and it can be rolled out nationally. So how the patient journey will look is that the patient who presents for an index prescription of one of the classes of drugs that I mentioned will be obviously offered an opportunity to participate in the trial. And if they do, then even at that point, the clinician has the option to issue the prescription or to delay it. So we're recommending that they wait until they have genetic results back, but of course they can start a patient off if it's clinically urgent. Participants recruited, the samples will be sent to the lab. The results will then be uploaded into the Geno system, that's a standalone tool, or in phase 2 that will go onto the EHR. The samples can be blood samples or saliva if blood's not going to be feasible. Again, the results are uploaded. The responsible clinician will then issue the prescription. So they don't have to follow the pharmacogenetic guidance, because obviously it may be that patient needs an alternative, but we don't know. That's just the pharmacogenetic information. We need to know what is the other patient factors that may mean that various alternatives are more or less suitable. And so we're working with SPS, which is a specialist pharmacy service, to look at the more complicated inquiries. So sometimes it'll be fairly simple to switch somebody to the alternative, but there may be situations where that's less easy, more of a grey area, and we need to work that out. So SPS are helping us a lot with that, because this is going to be a mainstream service. And we're also looking at longitudinal monitoring of the EHR for outcomes. So how often do these patients then present back at the GP for changes to their medicines? How frequently are they admitted to hospital? And is it different to a standard cohort? So we're looking at opportunities to engage with secure data environments so that we can compare that to national control cohorts. So yeah, as I say, think recruitment will open actually in May rather than in April in the Northwest, and then probably expand to the rest of England end of this year or early next. That's us, that's contact details. I hope it's a bit of a whistle-stop tour, but feel free to ask any questions about this or pharmacogenetics in general. Hi, straight up.
Well, yeah, no, when you were saying, you know, this is what the GPs, you're saying that the metabolism is unusual, look for an alternative. Are you going to explain in which direction it's unusual? So for the DPYDs, you do that because if they're a poor metabolizer, it makes the agents far more dangerous. Because
so
she led on to, because it brings you into, well, if the alternative, if there's other issues where you can't eat,
yeah,
you need to know, is it because the drugs are going to work, or it's actually going to make them potentially toxic?
yes, so if you see, this is a slightly rubbish example, I realise now, for a screenshot, because it's a normal. So if the phenotype said they were an intermediate metabolizer, the interpretation would then explain this patient is intermediate metabolizer, meaning they may have higher than normal concentrations and is therefore at increased risk of side effects. The guidance might still be that actually you can start at a normal dose, but just monitor them more closely, or you can be aware of it, or it will say they're a poor metabolizer, they're less likely to experience clinical benefit. What we know is that GPs are very busy, primary care clinicians, everyone's very busy in the NHS, and people don't want essays. We've been told very much that the guidance needs to be short. And we need to know very quickly, can I just use the drug that I need to use? And that's why we've done the colour coding, so that you can hopefully click on it. And if the guidance is go with the normal dose, it's green. If it's going to be monitor or change the dose a little bit, then it will be amber. And if it's stop, you need an alternative drug, it's red. There will be more information there. And we've looked at whether the guidance should have an extra option to click for more detail. Unsurprisingly to me, the GPs don't want more detail. The pharmacists really want more detail. Yes, please, can I have more detail? So, you know, we can't keep everybody happy with the system, but yeah, that there will be a bit of background to that. Oh God, Marie, I've seen you first.
Just on the back of that, is the system sufficient that if somebody's actually on concomitant meds that are either an enzyme inducer or an enzyme inhibitor, that will flag on this system, or is that the primary system of the GP?
Yeah, so that's a bit of the holy grail. This is a standalone system, so all this is the patient's NHS data and their sample going to the lab and saying their genotype. That's it. It doesn't have their kidney function or their liver in it. So there's or any of the concomitant meds. So in the standalone system, which is a stopgap so that we can start running the trial, no, we don't have that information. In the primary care system, when we get that integration, there will be some alerts that will overlap. So it may say if the alternative is something that's not on formulary, that then wouldn't pop up because those alerts need to mesh together. Enzyme inducers and inhibitors, I think there is not clinical decision support available to us. That's not something that we're working on. There are some companies that we've spoken to a little bit around trying to get that integrated information. Companies like First Data Bank that manage drug directories in secondary care, and a few other companies. And we're exploring with them what the options are around getting that information, but it does require all of the patient's prescriptions and everything being right on the record for that system to successfully integrate all of those factors. So I think the pharmacist will be quite safe for the job for a little while yet, before the computers take over.
Just to clarify, you said there's 70 targets on the 20 genes you set up as the panel. Is this based on the most common drugs used, or the most common drug interactions, or the most common genetic anomalies that are in the population? How do you select these, subselect?
So the variants are the most frequent variants across populations, or the ones with the most how's the word, clinical impact.
Yeah.
For those genes, the genes have been selected. Primarily, we're looking at CYP2C19, CYP2C9, SLC01B1, and CYP2D6, which are the ones that are relevant for our trigger drugs that we're using. The other genes that are on that panel, because that's what's available, these are commercially available panels. So we've not designed the panel per se. Okay. We've taken the panel that hits our needs. So if there were other,
trouble later because you're identifying something you don't know what.
so we're not reporting on patients' results of genes other than those 4 that I mentioned. So we're doing this kind of test broad report narrow.
Information about the 20,
but we're not going to be reporting on that, and that's because there isn't necessarily clinical guidance that's linked to those. So again, it's about what we can report back that's actually clinically useful to know. It may be that as evidence comes, or if the testing is commissioned, that we can start reporting those other results back. But it's, I suppose it's a bit like whole genome screening, where you don't actually report all of somebody's variation back to them when you're looking for a specific. Sorry.
So for the drugs that you showed in your progress study, is that the case for those as well, or is that where you're hoping to be, that you'll end up with?
That's where we're hoping to be. So none of these drugs already have mandatory commission testing routinely before starting. So I think you're talking about things like abacavir or fluorouracil. So there is some pharmacogenetic testing, but that's all single drug gene pairs, as we like it. Whereas this panel testing approach hasn't really been, certainly it's not been commissioned in the UK before. You see it in centres in the US and some other countries, but the panel approach has not been used and it's not commissioned at all. And none of those drugs are eligible for single drug gene pair testing yet on the NHS. So we'd like to get there, and it might be that as time goes on, there might be other drugs that we would like to have on the panel that are not on this commercially available ones. And that's about kind of engagement at a national level with the companies that develop these tests to see if they can be added.
Just want to tell you something.
Oh, please. Yeah, please do.
So over the years, from nursing patients, the amount of patients that I have given a codeine derivative to, and they've said things like, it's as if I've not had anything.
Yeah.
And to me, that's heartbreaking, because if you've got the facility to be able to take somebody's pain away or alleviate it, but to think that we're in this revolutionary phase now of identifying if they were never going to be, you know.
Yeah, and it's about 10% of people that won't metabolize codeine effectively enough to get analgesia. So it's not a small group of patients, you know, it's a significant chunk of people. There's also a proportion of people who metabolize it far too quickly and get really bad toxicity. They get opioid toxicity from it, or as some people I know, you say, oh, you get a bit of a buzz off codeine, don't you? No, I don't. I get effective pain relief, but I'm lucky I'm in that majority. So I think that's something that, you know, people can understand pharmacogenetics, because most people have taken a medicine at some point and known whether it's worked for them or not. And I think what Gavin talked about in his talk as well, about motivating people to want to take their medicine because they know there's genetic cause. If I had a panel and I knew that the statin that I was about to take was more likely to work for me because I don't have a genetic change, it would motivate me to take it. And I think that's another thing that we really need to explore, is around the shared decision making of when we're looking at people in the round and all of their medicines, building this in. So it's never standalone. All of this genomics is part of what everybody's already doing anyway. But you can use that, and like as you as a nurse or as any clinician, to know what I'm doing is more likely to work than because I've got something that I can narrow it down and optimize it for people. I think that's really important. So thanks, Marie. Okay. Lovely. Everyone gets a break now.
Quick,